Hi.
The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you for joining the Get Moving Physical Activity Colorectal Cancer webinar with Fight Colorectal Cancer and our guest presenter, Dr. Catherine Jankowski. So we're super excited to present information around physical activity and colorectal cancer, which I know is a huge topic for many survivors, advocates, and family members. So excited to move forward with today's webinar. Just a quick thanks to Michael, Sharon, the whole FITT CRC team who are on today helping support the webinar. And just a reminder that we do have social media following along. So on Twitter, the Facebook pages, and then also, of course, that today's webinar will be archived on the FITT CRC homepage, or excuse me, FITT CRC website. So go ahead and check out any of today's webinar tidbits as well as previous webinars on the FITT CRC site. So as we're getting ready to jump in, just a quick note that we want to include our chat feature. So in terms of the webinar technology, on the control panel, you will notice that there's an opportunity for you to ask questions. We encourage everyone, as questions come up, for you to go ahead and key those in. As you note, everyone is muted today, but we will have time with Sharon facilitating discussion after Dr. Jankowski's presentation today to facilitate a couple of questions. And then we just want to do a quick reminder that we do make sure that it's general education. We will not be providing any specific patient, specific individual level medical detail in terms of our questions. So just want to try to keep those as broad as possible related to patient education. So the FITT CRC webinar series is one definite resource that FITT CRC provides, but of course the mini magazines, the Guide in the Fight series, as well as the Tabooty podcast are additional modalities that we utilize to help with patient education and health promotion. So a quick note that if at any time you have any emergency or need any direct medical attention, 911 is noted, and of course today's webinar is in no way replacement for direct medical care, and we'd ask that you go ahead and connect with your medical team. So Dr. Kathy Jankowski is actually a team member of mine here at the University of Colorado. So of course I'm not sure that I introduced myself, but I work explicitly with FITT CRC in a direct partnership for advocacy and research and health promotion at the University of Colorado. And Dr. Jankowski is part of our team here, really focusing on cancer survivorship and her work in terms of thinking of the School of Medicine and Geriatric Medicine and the School of Nursing, and has had a lot of great formal training in terms of looking at research interventions for specific types of cancer, and particularly in the area of exercise and sex hormones and specific interventions to help with looking at the role of exercise and physical activity in cancer survivorship. So we're really excited. I know on screen you can see a number of Dr. Jankowski's accomplishments, but we're really happy to have Kathy join us today to share explicitly and good information around specifics around colorectal cancer and exercise. So I'm not sure why we have Dr. Goldberg, MD, but Kathy, you are you, so we'll go ahead and have you go ahead and present. So that made me laugh. Just a little bit of a slide issue right there, but we'll go ahead and punt to Kathy and have you take it away from here.
Well, that's my alias. Thanks, Andy.
Okay.
So let's see. I'll get my slides up. All right. Can everyone see my slides? Can I get a thumbs up, verbal thumbs up?
Verbal thumbs up.
Okay. So thank you very much. I really appreciate the opportunity to speak with the FIGHT Colorectal Cancer audience. I consider you to be very sophisticated in your knowledge of colorectal cancer, including advocacy for research and treatment programs and policies. So I hope that some aspect of today's presentation will hit upon any one or a number of those roles, as well as perhaps to give you some insights into your own personal exercise plans. If for some reason things are not clear, please make a note of that at the time. I'm happy to go back and explain in more detail during the question and answer period, which will conclude the webinar. So here we go. So just as Andy mentioned, my training is as an exercise physiologist. I also collect old-timey antique images of exercising people, especially exercising women. So I use this physical culture magazine cover, which is a nice way to introduce sort of an old style idea about what exercise was back in the 50s, but interestingly, coming back around to that again, but with actually some evidence base for that in our current day and age. So here are the objectives I hope to cover today. First is to weigh the balance and risk, the balance of risks and benefits of exercising. We have to admit that there are both, and they're not a static ratio, that it's a changing ratio, that you get a framework for planning exercise, and that you get to see some of the recent studies about the benefits of exercise, and then some tips on preparing to climb Quandary Peak next week. So to start off with, I want to go over what we consider our best practices to date in evaluating the risks and benefits and also planning exercise. And before we launch into this topic, it's a good idea to refresh on some terms that are often used interchangeably but are different. So human movement is actually the change of body position. So as you're listening to this webinar, you might be moving your arms, doing some things, you might be sitting and standing. All that's considered human movement. Physical activity means the body is not at rest. And so that means all movement that the person is doing is considered physical activity. In terms of the public health messaging, physical activity is used more often than exercise because exercise kind of has an evil connotation. But exercise is defined as planned physical activity. And as we go through today's material, you'll see that I address exercise specifically, so how to plan physical activity, how to make a plan. And I'll also talk about some studies that are about specific exercise interventions. In other words, the exercise was planned for the participants. And some studies that are more generalized to physical activity. So to start off with, I'd like to talk about the current physical activity recommendations for generally healthy adults in the US. And these have actually been adopted pretty much worldwide. And generally healthy here refers also to people who have medical conditions, but that are stable, either through medications or other types of treatments. So the current recommendations you see on the screen. The aerobic component comes in two levels. One is the higher level, which is, or the longer level, I should say, 150 minutes per week of moderate intensity cardiovascular endurance exercise. Well, that just means aerobic exercise. So I'll be using aerobic because it gives me more time to talk. Or you could do 70 minutes at a higher intensity of exercise. And the other component is muscle strengthening. So this is weightlifting, resistance training, calisthenics, if you remember that from your physical education days. Those are all considered muscle strengthening, and it's recommended to do those types of exercise on 2 or more days per week. And I have sort of an estimated risk and benefit profile here in the pie charts. So there's always some risk to exercise because, for example, you could sprain an ankle, or you could pull a muscle or cause a joint, discomfort. I could be out walking and trip on the sidewalk and fall. So there are some risks, but for the most part, they're quite minimal and very much outweighed by the benefits, because we know there are many benefits to exercise. We don't always know how exercise provides these benefits. But now I want to look at some accommodations we might have to make for some adults who maybe are stable or maybe coming out of a period of unstable health and going towards a period of more stability. So if we look at specifically at the risks and benefit profile for adults with CRC, the health benefits are many. and they're widespread, and they cover lots of different ways that we function every day. The risks are present, but they are manageable. The risks are reduced by education and progressive exercise, and by an individualized plan of exercise. And this includes also empowering the individual to monitor their own exercise and to learn what's a normal exercise response to them, as opposed to something that seems to be an exaggerated response on any particular day. And as we know, depending on what stage of cancer treatment, whether it's during treatment or recently completed or a long time since treatment, everybody has ups and downs in how they feel every day, but that some of those treatment or cancer-related side effects are also cyclical and so have to be taken into consideration. So how would I evaluate the exercise risk for an adult with CRC? Well, first of all, I'd want to know more about their active or completed treatment, so what their treatment profile looks like, the cycles and severity of fatigue, as well as other symptoms. We know that fatigue is quite widespread. It lingers. In some people, it's cyclical. So we want to know more about that. I would want to know about specific side effects of treatments or cancer or surgery that a person might be experiencing, and also what the severity of those side effects are. So I just put a couple here on the screen. And then outside of cancer, or maybe related to cancer, are comorbidities. So we know, for example, that with increasing age, there is an increased risk of high blood pressure, and also an increased risk of colon cancer. So we can't necessarily ignore the fact that someone might have high blood pressure. Now, exercise is good for trying to manage that, but we want to know more about that in terms of developing our risk profile and our exercise recommendations. Bone metastases come with many types of cancer treatments and cancer progression. So obviously that becomes very important, particularly with weight training exercises. And obesity, similarly, of course, there are many reasons for obesity. Obesity is widespread in our population. We have very good studies to show that there are good health benefits of people who are obese who exercise, whether they lose weight or not. So it's not all a matter of weight loss. And then, of course, with any exercise plan, we want to be able to consider orthopedic limitations. Now, I don't have a particular ongoing orthopedic limitation, but right now I'm dealing with plantar fasciitis. I've been dealing with it for way too long. But the point is that for right now, that is a specific, it might be temporary, I hope, orthopedic limitation that I would have to consider for my own exercise plan. And then I would also want to know if the primary care provider or primary oncologist believes that any type of exercise is okay, or if there are any exercise restrictions. For example, someone with an ostomy may have some restrictions on lifting weights or participating in contact sports. So I'm probably not going to be an advocate of rugby in the survivor with an ostomy, even though I'm a former rugby player myself. So you can see there are many things that I would want to know about when evaluating risk and determining a plan. Now, it might mean that a person has, their profile has a little bit more risk than the average healthy adult or medically stable adult, but this could be a very changeable profile as well. And so we expect that this risk to benefit ratio pie chart to actually be moving. And if I were better at graphics, I would have animated that. Now, how do we try to maximize the benefits and decrease the risks? Well, we know that the risks are going to be, the symptoms could be absent, or the risks could be not a non-issue. The risks might be present, but they might be mild and transient. And we sometimes have to accept certain limitations. So a risk can just be known and stable, or a risk could be changing. So with time and effort, we can maximize the benefits and decrease the risks. So what I want to go into now is a framework to guide your exercise plans. So we use the acronym called FITT-VP, and it basically answers the question, how much, how long, and how hard should I exercise? Another principle of exercise prescription is a concept called specificity of training. And to boil that down, it really means you get what you train for. So weight training improves muscle strength, but walking doesn't improve muscle strength that much. Aerobic training improves your wind or your ability to, your cardiovascular fitness, but it doesn't necessarily improve your muscle strength. So exercise training is very specific. Now, there are some crossovers, but they're minor compared to what we would expect the main benefits of the exercise type to be. What I always like to advocate is self-monitoring so that a person learns what feels challenging and why, and they can assess in this way. So my exercise feels harder today because of something I did intentionally. So I increased the weights in the gym, and that's why it feels harder. So that matches up. I have a challenging workout and it feels harder. That's a matchup. My exercise feels harder today because I feel unwell. So even though I'm doing the same exercise that I've been doing for the past 2 weeks, today I'm just not feeling up to it. It's feeling much harder. I don't know why, but I'm going to maybe take a day off or maybe back down a little bit on my exercise intensity or duration. Or my exercise feels easier today because I'm getting more fit. So maybe I've been doing the same walking plan for the past month and it doesn't feel like it's very hard at all anymore. So that's an indication that it might be time to create a small progressive challenge in your exercise plan. So now I want to break down the acronym of FITT-VP a little bit more. So the F stands for frequency. So that's the number of days per week. And it can also mean the number of sessions per day. So when people are feeling deconditioned, let's say they've had a long hospitalization and are getting back to sort of their normal routine, we might start off with just 10 minutes of exercise twice a day, rather than starting off with 20 minutes once a day, just to see how 10 minutes goes. If that goes well, we can start to increase the duration, which we'll talk about in a moment. The I stands for intensity, and this means the percent of the physiological maximum for that particular exercise. So it could be a percentage of your maximum heart rate. It could be a percentage of your maximum strength. When you're monitoring yourself without professional guidance, you want to be thinking about your perceived exertion. In other words, how hard are you working? And you can use a 0 to 10 scale that says 0 is very easy, 10 is the hardest thing I've ever done. You could set up a scale for yourself and actually on a calendar or a log or your smartphone, just put in, today was a 3, today was a 4. Oh, I increased my weights, today was a 7. So you can use that simple scale. Time stands also for duration. It just means the minute of exercise. Usually we use this with aerobic, not so much with strength training. The type of exercise is also sometimes called the mode, so what it is you're doing. So if it's aerobic, it might be walking or running or using an exercise bike or swimming. If it's resistance training, you might be using free weights or machine weights. You might be doing a different type of exercise, a mind-body type, might be yoga or Tai Chi. Those are all different types of modes of exercise. Then the V is for volume, and that's minutes per week. So remember that we talked about the recommendations, the public health recommendations for exercise. So that's a good example of how to describe a volume of exercise. So 150 minutes per week of moderate intensity or 75 minutes per week of moderate and vigorous intensity. Again, this tends to apply more to aerobic exercise. And then the P stands for progression. And that means where you are now and how that's going to change over the upcoming weeks, months, and hopefully years. So generally, we want to think about increasing someone's exercise challenge to the level that they can tolerate. So for example, one study that I'm going to talk about increased exercise to 300 minutes per week of moderate, or 100 minutes per week of moderate to vigorous intensity. So people didn't start out there, that was their goal. And there were several steps along the way to reach that goal. So that's what FITT-VP means. And now I want to give you some examples of how this would be applied, well, at least the FIT part, for aerobic exercise. So if we take frequency, we could translate that to 5 days per week, 1 session per day. Or I could modify that and say, okay, we're going to go for 5 days a week, but we're going to go for 3 shorter sessions per day. That may be much more appropriate for someone who's deconditioned. Intensity, we may say 70% of maximum heart rate, or a rate of perceived exertion of 7 on the 0 to 10 scale. Or that's a moderate intensity exercise. Or I may say, I think we should start at a lower intensity. So let's go with a perceived exertion of 5. Let's start there and then progress from that point. Time or duration can be 30 minutes per session, could be 10 minutes per session. In my very frail elderly clients, I might start off with 1 minute per session. So you can see these modifications are really, really vast, can be adapted to almost any condition. And then the type or modality of exercise, I could use walking for either of these plans and it would work particularly well. I could do the same for running or for bike riding. So that is FIT as an example for aerobic exercise. Now let's look at it for muscular strength and endurance. So here, if we follow the public health recommendations, our frequency would be 2 days per week and 1 session per day. If I want to modify that, I would say, okay, maybe 2 sessions per week, but let's have 2 short sessions per day. So maybe we're using resistance bands, so elastic bands. So we might do a set of ankle exercises in the morning using the resistance band and another set in the evening. And you can see some similarities to what we just talked about with the aerobic. So we can start off with a higher intensity and modify it to a lower intensity. We can start off with 30 to 60 minutes per session and maybe reduce that if 60 minutes is too much, or start at a lower rate. And then we might start off with weight machines at the gym and focus on large muscle groups, or we might focus on resistance bands and exercise at home, or targeted rehab. Maybe it's a physical therapy prescribed program. And these exercises could be done in a seated position, in a supine, which is lying on your back, or prone, which is lying on your stomach, depending on, for example, if you had osteoporosis. Doing some exercises seated might be better than standing. So that's an example of FIT for resistance exercise. So that gives you a little bit of a framework that you can think about and plug in your own favorite activity. If you've been thinking that your exercise program has gotten a little stale, maybe this is a good way to get you to the next level, or things you hadn't thought about in ways you can modify your exercise. Now I'd like to turn to the middle portion of the presentation today and talk about the state of the evidence for exercise for colorectal cancer survivors. Now, I was heartened to see so many studies that are in the planning stages for very specific exercise prescriptions and interventions for people with colorectal cancer. Now, a lot of those studies we're going to have to wait to see how they go. They'll be coming out in the next few years. We have some very good published studies. And so I decided to focus on an area that I think a direction that many studies are going in, which are dose response studies, which answer the question, how much exercise results in the best benefits with the least risk? So I want to share just a few of those with you today. So this first study is done by Justin Brown, and Justin did a study that looked at 2 different doses of exercise, either high dose or low dose exercise, walking for 6 months. And this was in 39 colon cancer survivors, and you can see their age, and about half were stage 3, and the other half stages 1 and 2. And this figure is showing you the prescribed exercise and whether people really did it. And so what you can see is that people start off at time 0. This is when they started in the study. And people in the low dose group were asked to build up to 150 minutes of walking per week. And they did that within 3 months. And then they plateaued and they stayed at their prescribed level. So this is actually really well-behaved research participants, the kind I love to have. The other group is the people that were randomized to the high dose exercise group, and they were asked to progress to 300 minutes of walking per week. And you can see that they did very well indeed. So it took a little bit longer to get there, which is not surprising because that's quite a bit of walking. But they did reach their peak. It was a little bit harder to maintain, but nonetheless, you can see that there's a big difference in the amount of exercise that the low dose group did compared to the high dose group over the course of 6 months of the study. So the intervention was delivered and carried out really well. An interesting side note to this study is if you were in it, they gave you a treadmill that you could have at home. So that was a really great study to be in. And so one of the outcomes that was investigated in this study was the changes in visceral fat and waist circumference. And so I wanted to look at the response in visceral fat and waist circumference from the different doses of exercise, because this is a great example of a dose response. So first of all, just to review what visceral fat is. So here's a belly, and here is the skin that we see on the outside of the belly. And this, there is a wall that's created by the muscles of the belly. And there's subcutaneous fat, and that sits between the skin and the muscle wall. Inside the muscle wall and where the organs are is another compartment which becomes, which accumulates fat, and that's called the visceral fat. And visceral fat is a focus of many research studies in many different populations, including healthy aging, because it increases with age. And it also has a lot of health implications. Specific to colorectal cancer, visceral fat, the amount of visceral fat is related to cancer incidence and also all-cause mortality in persons with colon cancer. I think we know less about persons with rectal cancer. In other health conditions, reducing visceral fat improves metabolic health, and exercise can reduce visceral fat. So what I would like to do is go through figure A, which is the upper figure on your screen. And what this is showing are the responses to the 3 groups of people that were in the study. So we had a control group. These are people that didn't do any walking for the 6 months. We have the low dose group and the high dose group. These are treadmill walkers. And what we see on the vertical axis is the change in visceral fat. So when you lose fat, you would expect to see a bar below the 0, and when you gain fat, you would expect to see it above the 0. So what we're seeing is over 6 months that the people in the control group actually increased their visceral fat area by about 5 centimeters. Whereas in the 2 exercise groups, we see that they lost visceral fat. And we also see a dose response from exercise in the sense that the people who did the higher dose of exercise, the 300 minutes per week of walking, actually lost more visceral fat than those who did the 150 minutes per week of walking. So this is a very fine example of a dose response between the volume of exercise and the loss of visceral fat. So what you can see is a stair-step difference in these changes. Now, the bottom graph is the change in waist circumference. And waist circumference is much easier to measure than visceral fat. And it's a very good, reliable measure of total abdominal fat, which means everything that you see here. If we put the tape measure around the person, we're measuring all of that. And once again, you see that with exercise, there's a decrease in waist circumference compared to the control group over 6 months. The low dose group didn't increase or decrease their waist circumference, and the high dose exercise group actually had a smaller waist after 6 months. So here again, we see the stair step or dose response in waist circumference from more exercise. So that's one example of a dose response of exercise that can be seen in an outcome that have, or two outcomes that have important health benefits. Went the wrong direction. Okay. Now let's talk about physical activity. Now we're going to talk more about physical activity in general and not a specific type of exercise. So this study was done to answer the question, does physical activity lower the rate of advanced adenomas? So these authors followed 300 CRC survivors for an average of 8 years. And these folks had surveillance colonoscopy 1 to 4 times after curative resection, and the number of times was dictated by their treatment plan, so it wasn't the same for everyone. So any polyps that were discovered had a pathological analysis. And then these 300 people also completed a physical activity questionnaire just one time. And the active people were labeled if they had if they reported 1 hour or more of exercise per week. So you see that about 70% of the people in the study, so about 200 people, were active at least 1 hour or more per week. And then the sedentary people were those who didn't do 1 hour. So they did less than an hour or no physical activity per week. And that's they asked one time, and they asked 5 years after their resection surgery. And yes, it turns out that the level of physical activity does have an effect on the incidence of advanced adenomas. And so let me walk you through this graph. So here across we have time. So it's in 200 months. It's kind of funny to think about time that way, but remember that people were followed for about 8 years. And we have the incidence of adenoma. So this is the number of adenomas per the number of people that were measured. So the more adenomas that are found, the greater the scale, the farther up on the scale you would be. The solid line represents the sedentary participants, and the dashed line kind of looks like a broken dashed line here on the reproduction are the active group. So the important thing to remember here is the higher up on the scale, the more adenomas were found. And what we can see is from very early on in the study, within the first 4 years, that people who were active had a lower incidence of advanced adenomas compared to the sedentary people. And that trend continued over the entire course of the study. Now, this is true for advanced adenomas, which were defined as being 9 centimeters or greater, but it wasn't true of total adenomas. So there was no effect of physical activity on total adenomas, but there is on the most serious adenomas. So I think this is very encouraging that becoming physically active, remember this is just 1 hour or more per week, is protective to some extent against the development of the recurrence of an advanced adenoma. So then they wanted to know, well, how much physical activity does it take to reduce the rate of advanced adenomas? And so they took all the exercisers and they broke those, their exercise records down into those people that exercise less than 1 hour per week. So these are the sedentary people. Then 1 to 3 hours, 3 to 5, or more than 5 hours per week. And again, what you can see is there is a big drop off in the rate of advanced adenomas in people who exercise even an hour, 1 to 3 hours per week. That's probably the biggest drop off you would see overall in the study. So that's very encouraging. It doesn't take a lot of exercise or physical activity, but it does take some. And then if we go to more than 5 hours per week, there is an additional reduced risk or rate of advanced adenomas coming back. And so it would tend to make us think that even more exercise is better. Now, don't know how many people were out in this group, and this was all self-reported exercise. So we'd want to confirm this in some different research approaches. But overall, I think the take-home message is there is a dose response between physical activity and the recurrence of an advanced adenoma, that even 1 hour a week is protective, and perhaps more exercise is even more protective. And then this study asked a different question. What is the relation between physical activity before and after CRC diagnosis to mortality? So does the physical activity done before diagnosis have a positive influence on life? Or is it just exercise done after, or both? So this is done using a technique called meta-analysis, which is a study of studies. These are all published peer-reviewed studies, and together, though, they encompass over 17,000 participants who were followed from 3.8 to almost 12 years, depending on the study. Their physical activity was determined by questionnaire or interview. And in this study, they also compared low and high levels of physical activity. So somewhat similar to what we talked about in the previous study. I'm going to show you some results over the next few slides that are similar in format. So I'll walk you through the layout, and then we'll talk about the results. So this is a graph that shows the mortality, the change in mortality risk if you were physically active before diagnosis and your colorectal cancer specific mortality. So to walk you through the format, one is if you are a poker player, or if you play dice or flip a coin, one means you have equal chance of being either greater than 1 or less than 1. So 1 is equal risk. Anything to the left of 1, so in the smaller number direction, indicates that mortality risk is decreased. Anything that goes to the right of the 1 to higher numbers would mean that mortality risk is increased. What you see are the citations. So these are each of the studies that had populations that fit pre-diagnosis physical activity and CRC specific mortality. And each study has a response line. And each line has a little box in the middle and a circle, and that's the middle or the average reduction in risk. And then the line that emerges shows how much variability there is. So what we look at overall are, do most of the studies fall below the 1, which is equal risk, or do they fall above the 1? So here we can see that most studies, at least as far as their averages go, fall to the left, indicating a decreased mortality risk. And what we see with this diamond is if you put all of these studies together and all of their variability, this is the average amount of risk reduction we would expect to see. And that comes out to about a 20% reduction in CRC-specific mortality. Now remember, this is the physical activity done before diagnosis. So about a 20% decrease in mortality. Now this looks very similar, but the outcome here is overall mortality. You can see again, the big diamond is to the left of the 1, indicating a decrease in mortality risk, and the magnitude of that is about 20%. So if we put both of those figures together, we can conclude that physical activity that was done before diagnosis would decrease mortality, either all-cause or CRC related, about 20%. Now, let's talk about physical activity done after diagnosis. We know a little bit less about this, but overall, if we look at the big diamond at the bottom, we can still see that it shifted to the left. And this is post-diagnosis physical activity on CRC-specific mortality. So again, we're seeing about a 25% decrease. And this graph shows overall mortality, and here we're seeing about a 30% decrease. So if we were to put all four of those graphs together, we could conclude that physical activity, whether before diagnosis or after diagnosis of CRC, is associated with a decreased mortality risk for all causes of mortality, as well as CRC specific. So promoting physical activity, even after cancer diagnosis, even if you hadn't been physically active before, is still a reasonable approach to improving health benefits. Now, I mentioned that these authors also did a comparison between high and low levels of physical activity. So this kind of gets us back to that dose response question that we talked about before. And these graphs, I didn't split them out for you, but the only real difference here is that to the left of the one favors high physical activity, and to the right of the one favors low physical activity. And what we can see overall is that higher levels of physical activity are associated with decreased CRC specific and overall mortality compared to lower levels of physical activity. And I can't give you a specific definition of high or low level of physical activity because that was specific to each of the studies in this meta-analysis. But overall, we're looking at anywhere from a 25 to a 50% reduction in mortality. So I know you want to know specifics. In this case, they are not available. But the take-home message is higher levels of physical activity may be more protective. Now, I want to turn table again and talk about climbing a 14er, because I know that some of you are going to be taking on that goal next week. First of all, there is a link in this seminar that will bring you to a gear list for the 14ers.com website. So people with a lot of experience climbing 14ers have a very extensive list of gear for you to look at there. So I encourage you to peruse there. And also be nice to see some photos of you on that website. So a quick equipment list is shown here. This comes from 5280 magazine back in 2013. But I also have a list for that I call extra emphasis for those of you with CRC that are going to be doing this challenge. So one is hydration, and to plan your hydration for the days before and the days after, as well as the day of the excursion. I know you're going to drink a lot of water the day of. You're already prepared for that. But you can also start to hydrate before, well before, I would say 3 or more days before, and also keep up that hydration afterwards. And then the food, you want to select food that you know you tolerate. This is not a time to experiment with foods that might be upsetting, that might be cause GI distress during a time where you're doing a lot of exertion. So when you are very physically active, the blood flow to your stomach will be decreased because that blood is going to your active muscles. So you want to eat small amounts, but often, and silly of me to say this, but actually to practice eating. So if you're not accustomed to eating while exercise, it's good to try that out, even if you're just going to do maybe a shorter practice hike to try out your new shoes. That's a good time to try out the foods that you're also planning to bring with you. Blisters are inevitable, so I always have a full complement of those new blister bandages, which are great. and moleskin. You might bring second skin to put on, perhaps leave it in your car and take care of that afterwards. You can prevent blisters by having shoes that are well-fitting and also broken in, and also by having wicking socks, and to bring spare socks. If you get stuck in a downpour, or if you're a person who perspires a lot, you might want to change your socks once or twice during the course of the hike. And then no one wants to talk about this, but remember to bring your own toilet paper in a plastic bag to put something with, because you're going to be in an area where there are no trash cans, but you're responsible to pack out all of your trash. So don't be embarrassed by that. So now let's talk about some things that might occur and how you could handle it. So what if you develop altitude sickness? So you have a headache, maybe you're nauseous, maybe you've had a little vomiting. Then what you should do is rest and return to a lower elevation. Take a buddy with you who can help out in the case that you need help. Let's say you become faint or weak. They can help you to sit down. They can get water out of your pack for you and stay with you in a safe place. What if you feel winded? If you're breathing hard and your heart rate is high, well, if you're uncomfortable with that, it's totally appropriate to rest and to slow down and take frequent breaks. Climbing a 14er is very hard work. You're climbing up a very steep staircase that is very long and with less oxygen available. There's the same amount of oxygen in the air, but getting it out of the air is a little more difficult. So you are going to feel winded. Everyone does. And you will just have to adjust your hiking speed and the amount of rests that you take. Taking frequent breaks is a good idea for getting your water in, and also taking small amounts of food, and also catching up and chatting with your friends and commenting on the great view. What if you encounter bad weather? Well, shelter in place or return to a lower elevation. Remember that here in Colorado, you want to be off the peak by noon, or at least below, if you can't get off the peak, at least below tree level to prevent lightning strikes. You want to put on a hat, gloves, and wind gear. Even if it's not quite that cold yet, have all that ready, because when you're cold, it's really hard to get that stuff out of your pack and put it all on. And remember to keep drinking and eating. Sometimes people get very distracted by the fact that they're cold or they're struggling with the wind, but it's very important to keep sipping water and to keep ingesting fuel. What if you're having so much fun you don't want to leave? You're loving the mountain goats, then you're going to take photos, you're going to enjoy the view, you're going to breathe, and you're going to stick to your plan. You don't want to go beyond your capabilities or push the weather just because you're having so much fun, because that can turn on you very quickly. What if you're going slow and you won't be able to do the summit today? Well, appreciate where you are, because you've done something tremendous. You're in beautiful outdoor Colorado. Enjoy the day, whatever it brings. And that's the end of my presentation. So I turn it back over to Q&A.
Thank you so much, Dr. Jankowski. We really appreciate it. Awesome presentation. Let me go ahead and take the controllers back here for a moment. We do have a couple questions that came through. And just as a reminder, to those that are listening live, in your control panel on the right-hand side, you can type in questions there, and I will see them, and we can add them to our Q&A. So here we go. All right, so while I get this all set up over on my end, I'll go ahead and start with some of the questions. What do you recommend a patient takes as next steps to begin an exercise program if they hadn't been exercising previous to their diagnosis?
Okay, everybody can hear me okay?
Yes.
Okay, would you mind repeating the question?
Absolutely. What do you recommend a patient takes as next steps to begin an exercise program if they weren't active prior to their diagnosis?
So my recommendation is to begin very conservatively. Ideally, maybe you could get some personal training or even physical therapy. But if you're doing it on your own, I would start with trying to identify an exercise you like, because the best exercise is the exercise you like. So start with what you like or what you dislike the least if you're not a big exercise fan. Something that's convenient for you to do, maybe that's walking in your neighborhood, or maybe it's going to a gym. Try out some different treadmills perhaps, or stationary bikes, and start with maybe 10 or 15 minutes and see how it goes. Get familiar with the equipment, or when you're out walking in your neighborhood, kind of keep a watch handy and see, well, how long does it take me to go around the block? And then come up with a plan. So make a calendar and come up with a plan with yourself to do this, let's say 3 times a week to get started. And see how manageable that is. Fit it into your daily routine. Obviously, you have a lot of other things to fit in during the day. As you get into that routine with that level of exercise, then you can begin to think about walking a little bit longer or walking more days a week. I always recommend increasing the duration of the exercise or the frequency, the number of days a week, before increasing the intensity. You can use the 0 to 10 scale, where 0 is no work at all, 10 is the hardest work you've ever done. And you want to kind of start out at about a 5 when you get started. And you can always increase that intensity by, for example, walking a little bit faster. You can use things like a smartwatch or a Fitbit or any kind of equipment like that if you'd like to, if you like the techie thing. They're great motivators. They're great for keeping records. But, you know, for me, I'm a person who has to look at the computer all day long. I like to just go out there and have the time to myself and think about, okay, I'm going to be doing this walk around the block this morning, and it's going to take me about 30 minutes, and that's good for me, and I'm going to try to do that 5 times a week. And that's how I keep track.
Great, thank you. A couple more questions. The next one, will exercise contribute to cancer-related fatigue?
That is a really great question. And the best evidence I have is not exactly in colorectal cancer, but I am going to extrapolate from other cancer types. There is some evidence that exercise helps to reduce fatigue related to cancer. There are some studies that show that there's no change in fatigue, but I haven't seen very many studies that say that exercise increases fatigue. Now, I think this is a very personalized symptom, and I think everyone needs to adjust for themselves. If exercise is causing excessive fatigue beyond what you might expect from starting a new exercise program, then maybe you need to back off on that. And if it's persistent, if you try to exercise a number of times, you've decreased the intensity, you've stepped down, and you're still feeling very tired from it, then I think you might want to follow up with your care provider. Obviously we know that anemia is a very common side effect and is monitored very closely in cancer survivors, so we might want to get that checked. So also planning your exercise for the time of day when you seem to have the most energy is another way to mitigate any extra fatigue that the exercise might be causing.
Wonderful, thank you. And this is our last question that has come through. So again, if you have questions, listeners out there, please type them in. So our next question, are there any precautions in terms of hiking with an ostomy at high elevation?
Precautions of an ostomy at high elevation. So I think thinking about my own physiological responses of hiking at high altitude, your diaphragm is going to be moving a lot because you're going to be trying to move a lot of air through your lungs. to get proper oxygenation to continue to move. And so that, that movement in your abdominal area might cause a little bit of ostomy irritation. There's no, I think there's no specific risk involved. I think if you are starting to feel discomfort around the ostomy area with lower levels of intensity at lower elevation, then you will have to progress very slowly and monitor that as you go higher. The other thing is to be careful that if you're doing, some of the parts of the trail might be a little bit tight, or maybe causing you to need some support with your hands, that you don't bump your ostomy area into, say, a stone or a rail that might be in the trail area. So just be protective of that area.
Great, thank you. And FITT COC does have a blog that went out earlier this month specifically about hiking with an ostomy. So I'll make sure that that's linked in to the
fantastic.
webinar. Yeah, we do have a final question that just came through. Any risk of exercising while on chemo, and what could happen if you over-exercise while on chemo?
So what we know about exercising with chemo is that so you are going to be a little bit more prone to dehydration and maybe some skin irritation as well, and thermoregulation. So it might be a little bit more challenging to control your body heat, and it could be that you feel really chilly, or it could be that you are bothered by being overheated, or you can go from one extreme to the other. So what patients have told me is that they exercise fine like the day after chemo, but if they're going for, let's say, infusion, it's like the 2 to 4 days after chemo infusion that they don't feel really well, and so they don't plan to do their exercise on those days. So that's again where the learning about yourself and how to individualize your exercise program. You will do that in the context of your chemotherapy plan as well. Are there harms? Again, we would not want to see any more risk of dehydration. So being cognizant of your fluid intakes. You may feel a little weak because you may not be able to eat very much, or maybe you've had some vomiting or diarrhea that's left you a little weak. And so your intensity level and your duration level may go down for a few days. Generally speaking, in between cycles, people seem to be able to work back up to what they were doing. And so I just, the ups and downs can sometimes be a little discouraging, but just remember that doing something is probably better than doing nothing. But if you're feeling just very, very poorly, it's to be expected. It's part of the chemotherapy side effects that we try to do things about, but we can't. Give yourself a pass card for the days that you're not feeling really well. I also recommend on days or when you're starting off and you're trying to get your bearings on what your exercise level can be during treatment, is not to exercise alone. So if you can bring a family member, a friend with you to walk, just in case you start to feel a little lightheaded or weak, that you're not by yourself. And it's great to walk your dog, but they're not that good at using iPhones yet. So if you don't have a buddy to walk with you, at least bring your phone with you, and also let someone else know that you're going out for your exercise.
Great advice. All right, well, I think that takes us to the hour. Dr. Jankowski, thank you again for a wonderful presentation. And thank you to all the listeners joining us live, and have a wonderful day.
Thank you very much. Keep exercising.
Thank you, Kathy. That was awesome. Oh, sorry, I muted you. Hold on.